arthritis is just a wear and tear. Every one of us will get it.
Women are more prone to getting osteoarthritis than men. And if you have all four components, then
You're doomed.
we're not treating the disease, we're treating the symptoms. And opiates should never be given in osteoarthritis. Steroids, they have their benefits. What you don't know is that in the first 24 hours it kills about 80% of the chondrocytes in your knee. The more injections you have, the quicker you'll go to surgery, because it does basically destroy the joint over a period of time. I think we've done a crap job.
Thank you, Peter, for joining me on this podcast today.
My pleasure. Looking forward to it.
And we got a very long conversation to have. What I'm planning to do is split this into possibly of 3 podcasts so that people get that information without fatigue all the time. And my audience will be loads of my client group, patients who are looking for treatments for their arthritis, and also loads of physios and medical professionals who follow me on LinkedIn and who regularly follow our social media from the business itself. Those are the people will need to listen to all of those things.
Okay, I'll keep it simple.
Perfect. Keep it simple. And that's the main reason we say keep it moving,
Okay.
Keep it going. The first thing we want to talk about, osteoarthritis of the knee joint. But beforehand, I want to, tell the audience that I'm a non-medical prescriber by, qualification, and I'm also a physiotherapist, and I've been injecting steroids and hyaluronic acid into the joints for the last 14 years. I've been qualified by Society of Orthopedic Medicine 14 years ago, and ever since I've been injecting. And I worked in the NHS for 10, 15 years doing the same. So I'm very well versed with the drugs, treatment options, prescribing drugs to the patients to manage the pain. And likewise, you've been a doctor here as well. Let us hear from you.
Okay, thank you. Well, my name's Peter Shaw. I am currently the Senior Director for Medical Education at Bioventus in the United States. I trained as a doctor at Charing Cross Hospital in London many years ago, qualified in 1985. That ages me considerably, doesn't it? And spent a number of years doing hospital medicine. My first jobs were actually in orthopedic surgery, and then I transferred into other areas. Ended up as a general practitioner in Maidenhead in Berkshire, where I was for nearly 16 years. While I was there, I looked after Maidenhead Rugby Club for nearly 13 years as team doctor.
Okay.
And then, long story, which I won't share with you, but I ended up moving to the United States full-time in 2008 and then moved into the pharmaceutical industry. And I've had the pleasure of working with many of the companies that produce hyaluronic acids for years. And most latterly, I worked at Ferring Pharmaceuticals for 3 years, where they have a hyaluronic acid which is called Euflexa. Most of its use is in the United States. And then 6 years ago, I moved to Bioventus. My actual involvement with hyaluronic acid started in the early 1990s when I was using it in clinical practice.
1990s?
Yeah, so probably around about 93, 94.
Wow.
I think was the first time I did knee injections. Then there were 2 hyaluronic acid products available.
Yes.
There's now nearly 70 available around the world. And
Different brands
it's increasing, yeah. And I'm sure we'll get to talk about that later.
Yes.
Everybody always lumps them together as being the same, and they are all very, very different.
This is the point, sometime when people look into social media or Instagram for knee pain and hip pain, there are plenty of information. Some of them are quite misinformation, in my opinion. And today you are hearing from a qualified doctor from Charing Cross Hospital. And also he worked as a GP for 16 years. So whatever he says, it's pretty accurate. And I've been involved in the same field for 15 years. And I've seen all kind of arthritic patients, and I do specialize in joints and especially hip and knees, and also the spinal treatments. So let's keep it simple. In my understanding so far, arthritis is just a wear and tear. Every one of us will get it, and it's an older age. We all will have it. Some people are fortunate not to have any symptoms. Some people are unfortunate to have symptoms. What is your take on it?
That's really where we've gone wrong over the years.
Already we've gone wrong.
You know, I'm probably as guilty as any. You know, in years ago, we just always talked about osteoarthritis as being the wear and tear disease.
Yes.
The more stresses and strains you put on a joint, the more problems you're going to have later in life. But that doesn't really explain what goes on. So why do you have people who are 90 years old and who can still run marathons?
I've seen them.
You have 50-year-olds who are having knee replacements or hip replacements done. So it's a little bit more complicated than just the wear and tear. Each joint that's affected is in a different way. And we're not going to talk about rheumatoid arthritis.
Yes.
Because that's a completely different condition. But osteoarthritis is a primary condition, or it's a secondary condition. And the secondary part of it is when you develop osteoarthritis because of something that's happened.
Yes, like a trauma.
Trauma. And typically that's more the case with ankles, where most ankle arthritis is due to a traumatic injury at some point. So it tends to occur at a younger age.
Yes.
And it has a different etiology. And quite often can just be one joint affected because of injury.
Wow, okay.
So secondary osteoarthritis, let's say football players
Yes.
who've had knee injuries and that's the only joint affected, is what in the past we always termed as being the wear and tear disease. But primary osteoarthritis is a combination of problems. You can look at it more like a systemic disease in many ways. Although there are localized problems, and one joint may be affected more than the other. It is unusual for just one joint to be affected. And there are certain people who are much more likely to develop osteoarthritis.
Okay.
So the first problem is if you happen to have two X chromosomes. So women are more prone to getting osteoarthritis than men. That's the first group. And as they get older, their likelihood of getting osteoarthritis increases at a greater rate than it does with men.
Wow.
Then there are other things that add to that lifetime risk. So obesity is another one. And it's not just because obesity adds on weight and adds on strain to the joints that you're putting on.
Yes.
It's the other problems associated with adipose tissue and the effect that has on mediators and cytokines in the joint which promote inflammation. So they accelerate the disease process. So that's twofold there. And then there's another group of patients who are more likely to develop osteoarthritis. And those are people that general practitioners are seeing every day in their clinical practice. And they're people with what we call the metabolic syndrome. And the metabolic syndrome consists of four components: obesity, high blood pressure, abnormal cholesterol, and abnormal glucose tolerance.
Wow.
And with each of those components of the metabolic syndrome, your lifetime risk of getting osteoarthritis goes up.
Getting greater and greater.
And if you have all four components, then
you're doomed.
That's it. That's it. You're done.
You're
not
doomed.
exactly. But yes, your risk goes up considerably. And again, there's a difference between men and women. So in men, the risk goes up like this. And in women, it goes up like that with each of the components of the metabolic syndrome. So when you see doctors about this, it's not just treating the symptoms associated with the osteoarthritis. It needs to be a holistic approach. It's just like with diabetes. In diabetes, you need to manage people's weight and their cholesterol and
lifestyle,
and their blood pressure, as much as you need to manage their blood sugar. And if you only manage the blood sugar, then they don't do as well as if you manage their blood pressure and their cholesterol and their weight and exercise and things. So all of these are part of the treatment paradigm that we need in osteoarthritis.
But Dr. Shah, you won't believe it. Never been discussed in our primary care in UK or in the hospitals, all about these four components. we all thought that women are more likely to have this osteoarthritis in the knees and hips because of the wider pelvis. They develop biomechanical changes in the knee joint, and the weight bearing goes more in the joint. As they get older, they get it.
Yeah.
But it's a completely different level.
It is. I mean, gait is very important as well, and I'm sure you're well aware of that in the physiotherapy field, and it just adds to the problems associated with it. You know, so people who are born with gait problems and other disabilities, they're much more likely to get osteoarthritis than others as well, because of the way that they walk and the gait issues associated maybe with cerebral palsy or, you know, the neuromuscular conditions and problems associated with that.
Perfect. And so, in your opinion, the osteoarthritis of any joint need to be treated as a systemic disease, stage by stage, and need to target the core problem rather than just putting them with the ibuprofen, naproxen, or any non-steroidal anti-inflammatory drugs and just fobbing them off.
You're opening up cans of worms here.
Oh my God.
You don't know what you've let yourself in for. Okay, so treatment of osteoarthritis, and this is where we have got it wrong time immemorial, because all we are doing until very recently is really treating the symptoms.
That's true. That's true.
We're not treating the disease, we're treating the symptoms. And I'm going to say this is before things like hyaluronic acid and stem cells and PRP came along. Is before that, the treatment that we had available to us was physical therapy,
Yeah.
painkillers, opiates, and don't get me onto opiates because
Oh my God,
you'll regret
that's my favorite subject to talk
all right,
about.
well, we'll talk about that anyway. And then surgery.
Yes.
And none of those actually treat osteoarthritis. They treat the symptoms. And if you think about it, and I'm sure all your patients will recognize this, is what takes a patient to see a clinician with osteoarthritis? They don't come along and say, hey, doc, I've got osteoarthritis. They say, I've got pain,
Stiffness.
which doesn't get better, other symptoms, and I can't go up and down stairs.
Yes.
So they complain of symptoms, and I think we're guilty of this.
Yep.
Is we treat the symptoms and we monitor the disease by the progression in symptoms. So if somebody goes away and you give them the treatment and they go away and the pain goes, they don't come back to you. They come back when that's no longer working and they start to get pain or stiffness again. And then as clinicians, we have a tendency to manage the disease based on the symptoms that they come along. So once one treatment stops giving them pain relief,
Yep.
we move on to another one. And when all of the treatments we've got fails, we give them a new joint.
Oh, God.
But all we're doing is treating the symptoms. Because you replace a knee joint and they've got pain in their hip.
The hips.
And the pain may go from their knee and they'll come back to see, well, yeah, my knee's okay now, but my hip hurts. Or my other knee hurts. Or my shoulder hurts. Or my fingers hurt. Because it affects multiple joints. Now, we still do not have the true, what we call D mode, so DMOAD, which is the disease-modifying drug in osteoarthritis. The thing that revolutionized the treatment of rheumatoid arthritis was when the first DMARDs were launched. Those were the disease-modifying anti-rheumatic drugs.
Agents, yeah.
And, you know, I mean, some people say we've cured rheumatoid arthritis. You know, we don't see the problems of what we did 20 years ago because of these drugs. We don't really have any in osteoarthritis because we're still treating individual joints. We haven't found the one holy grail which you can give somebody as a drug by mouth or by injection, which is going to affect the progression of osteoarthritis in all their joints. So what we're doing is treating symptoms. And then if you think about it, what do we use? Well, people go to the pharmacist and they buy ibuprofen.
Yes.
Or they buy paracetamol. Or they buy one of the other ones that are available over the counter. Now, if you think about it, none of these drugs were ever designed to be taken multiple times a day for multiple years on end. All painkillers are designed for acute pain.
Yes, that's right.
3-4 times a day for a period of time, and then the pain goes. Osteoarthritis doesn't go when you stop taking the pills.
Painkillers,
it
yes.
comes back.
Yes.
So you have to take them long term. And then you think about the problems associated with taking paracetamol, 4 grams of paracetamol every day. Your body can cope with that. Go over 4 grams, your liver can fail.
Yes. Kidneys.
Kidneys fail. And the cardiovascular problems associated with taking anti-inflammatory drugs every day, and the fact that these drugs burn holes in your stomach over a period of time,
Yep.
and you then have to start taking...
Lansoprazole, omeprazole.
Exactly. You have to start taking some sort of cytoprotectant for your stomach because you're popping 800 milligrams of ibuprofen twice a day for 20 years.
Oh, my God.
So, here we have drugs that are... They're painkillers, but they don't affect the disease process at all. And then if you want to talk about opiates should never be given in osteoarthritis because all they do is create people who are addicted to opiates. And there's a number of studies that show that those people who are taking opiates, who then have a knee replacement, end up taking more
opiates
after the surgery than they were before.
What's the point then?
And opiates are even worse because not only do they do absolutely nothing for the disease process, is they're dangerous. I mean, I work in the United States now, and there are 90,000 deaths a year in the United States
Because of the
due
opiates.
to prescription opiates.
Overdose or just a normal prescription?
Well, they're on prescription. They may overdose on.
Yeah.
But it's associated with the fasting. That's why there's all these lawsuits about, for the companies that make oxycodone and those ones, because they're not a treatment for a disease. They're a treatment for a symptom.
Symptoms management. Let me take you a couple of steps backward and talk about the stages of osteoarthritis in a knee joint or a hip joint. In my understanding, we got 3 stages. One is early acute stages, then you got a subacute and chronic stage, and then finally you're bone on bone, then you need a knee replacement or a hip replacement. But there are loads of chemical changes goes through the cartilages and the menisci, which is in between the joints. Talk about that for me, please.
Okay, so it's a progressive disease once you've got it. Irrespective of whether it's primary or secondary, it does progress. And it progresses for a number of reasons. Firstly, we're getting older.
Yep.
And our ability to repair tissues. Cartilage and structures within the joints tend to have a relatively poor blood supply.
That's true.
So that's another reason, we need a good blood supply in order to heal. You touch yourself and in 3 days
you're healed because plenty of blood comes out.
Supply. And typically those tissues that have a poor blood supply heal less well. There's in orthopedics, there's some classic ones. There's the scaphoid bone in the wrist, which has a poor blood supply. And the risk of that not healing when you break it is 10 times what it is in other bones. And the David Beckham's foot,
Achilles.
The fifth metatarsal.
Yes, okay.
So that's another one that classically has a poor blood supply and heals, is more likely to go to not healing, so non-union if you break it, than other bones. So blood supply is very important as one thing. Now, the way we classify osteoarthritis is it's done partly clinically on symptoms, which is how you tend to treat patients, but radiologically, so on X-ray. So X-rays of the knee will show you the progression of the disease.
Yes.
And we use a rating scale called the Kellegren-Lawrence rating scale.
Yes.
And it goes from 0 to 4. 0 is no arthritis, and 4 means, hello, surgeon, I'm coming for a new knee. And it's the progression through that, and what you see is the damage done to the knee. So you see the cartilage break down, you see the joint space itself
narrowing,
narrower and narrower and narrower, and by the time you got to 4, we call it bone on bone.
Bone on
because
bone,
literally there's bone touching bone, and there's nothing in between. At that point, most of the treatments that we have lose their efficacy.
Yes.
So they're not as good once you get to that point because you've got bone grinding against bone.
Yes. So mechanical problems.
Anything that you put in that has biomechanical properties is fighting a losing battle. The time to treat it is much earlier. And we do know that if you treat it at an earlier stage, you can at least delay and maybe even prevent the progression of the disease to that point. Unfortunately, most of the products that have that surgery delaying outcome and capacity tend to get used too late in the disease process. And that's partly because the other treatments available are a lot cheaper, so get approved. And a lot of authorities around the world, and here as well, say you can't use this until others have failed.
That's true. That's very common in national health service.
And I know at some point we're going to talk about steroids.
Yes.
That's another soapbox you probably don't want me to get onto. But steroids, they have their benefits.
Yes.
And I know as patients you'll love to get your shot of steroid because you can walk out of that office and you feel great. What you don't know is that in the first 24 hours it kills about 80% of the chondrocytes in your knee and is actually cytotoxic. And the more injections you have, the quicker you'll go to surgery because it does basically destroy the joint over a period of time. I mean, even when I went to medical school, we were told, don't put repeated steroids into a joint because you will only cause problems. And I know a lot of surgeons say, I cannot give you another steroid because it's just not good clinical practice. Now, they have their place.
Yes, yes.
And I'll save my comments for that when you want to get to
when
that.
I get to it.
Actually get to that.
You know, before I forget this question, from your qualifying period until now, do you think the treatment of osteoarthritis have evolved significantly and we have done a great job for the public as offering a very revolutionizing treatment or not at all?
No, I think we've done a crap job, to be honest with you.
I can't believe it.
I present a lot to everything from sort of medical students to physical therapists.
And to BBC as well?
Oh, well, not anymore, but a long time ago I did, yes. On this thing. And I show a slide of the treatment of osteoarthritis. And apart from the little box in the middle, which includes hyaluronic acid, PRP, stem cells, it has not changed in 35 years.
God.
Little things have changed. We have newer anti-inflammatory drugs which are a little bit more specific.
Kinder to the body.
A little bit kinder. I mean, one wasn't, which I'm sure everybody remembers, Vioxx, when that was withdrawn a few years ago.
Okay.
But yeah, as a whole, really the treatment hasn't changed. You know, what do we have? We have opiates, anti-inflammatories, paracetamol, physical therapy, bracing, arthroscopy, surgery. Can you name any of those that have changed much in the last 25, 30 years?
I think recently they banned arthroscopy for osteoarthritis as a treatment option, as a nice guidelines, but still happening. Still, I've seen surgeons doing it in private hospitals, private clinics. The arthroscopy is still being performed, but patients are loving it.
Yeah.
Lavage is the treatment.
Yeah, I mean, basically you're washing out all of those things that accelerate the disease process. So, I mean, I have a lovely slide that I show in a presentation, which is a picture taken at arthroscopy of a knee joint.
Yes.
And at the beginning of the arthroscopy, there's this red inflamed inside of a knee joint. 20 minutes later, a photograph was taken and it looks like ivory. It's white and clean. And the surgeon who shares those photographs with me, he's a surgeon called Dr. Dasser out of LSU in Louisiana. And thank you, Vinod, for your pictures. All I did in that 20 minutes was irrigate the knee with normal saline. So he was just flushing out the knee with normal saline.
Wow.
And it flushes out all of the bad things that are going on.
Inflammatory
products. It probably
products.
wouldn't last very long, but it just shows you that in a lot of the clinical trials that we'll talk about later
Yes.
on hyaluronic acid, the comparator is not what is deemed placebo. It's normal saline, which has a physiological effect when you put it into a joint.
Then why do we use normal saline as a placebo effect in loads of researches?
It doesn't. It's not a placebo effect. It has a physiological
Effect.
in the joint. But I mean, if you think about what are you going to do in a clinical trial where you're trying to hoodwink someone that you're doing the same thing, if you don't stick a needle into their knee in both treatment arms? I mean, in some studies they do what's called a sham injection.
Yes.
Where you inject, but you don't actually put anything in against things. But in fact, almost all of the hyaluronic acid studies and steroid studies, the comparator is either phosphate buffered saline or normal saline, which
Wow.
has a physiological action within the knee. And there's a number of papers which talk about what effect saline has. There was one study done by a rheumatologist in Boston, and over a 2-year period, he compared two groups of patients.
Okay.
So they were randomized to get 3 monthly injections of steroid, a very commonly used one, triamcinolone,
Okay.
over 2 years.
Okay.
And the other group had 3 monthly injections of normal saline for 2 years. And when you looked at the result, there was no difference in pain control between the two groups.
Oh, God.
No difference. The only difference was the patients that got steroid every 3 months for 2 years, so they had 8 injections of steroid,
Yes.
got accelerated cartilage degeneration over that period.
Controlisis. Oh, my God.
Precisely.
Now, I want to talk to you about the holy grail of treatment options for the arthritis, because that's what all my client group would be looking forward to beforehand. I'm sure this NSAIDs, which is ibuprofen and all the naproxen and everything, have a place in it, or I don't know whether they have any place in the treatment of arthritis or not at all. And when do you start prescribing opiates? Or do you think that's a very bad practice to prescribe opiates?
My first answer to that is the last question, which is why on earth would you ever prescribe opiates for osteoarthritis? Can you give me a reason?
It's commonly done, but I don't have a reason. I don't have a reason. Every patient comes with the opiates as a prescribed drug.
Why? What are you doing?
We're just,
You're constipating them,
Yep.
because they've got codeine or morphine or other thing in it.
cocodamol is a very commonly used drug here.
You are not treating the osteoarthritis at all. You're treating the symptom of
Yes,
pain.
yes,
And you're making them addicted to opiates,
yes.
which does them no good at all.
That's the entry-level prescription here.
I understand why and how it's
Yeah.
done, and the reasons it's often done is that authorities block the use of other products because they're deemed more expensive and have less evidence behind them. But can anybody show me any evidence that taking cocodamol, codidromol, coproximol has any effect on osteoarthritis at all?
No, I haven't seen much.
There was a lovely study that was published in, I think it was 2017, in the American Journal of Pharmacy Benefits. And it showed that by having hyaluronic acid injections, you reduce the amount of prescription analgesics that patients were taking for 6 months after an injection.
God. Yep.
And yet these products, and I know we're going to talk about them a lot more
Yes.
later on, and maybe in the next one, is that there are reasons why they've got a bad press over the years.
Yes.
And I fully accept that. But I also would say that most of the research done on them has not been the right research.
Okay, they were embarking on the wrong directions. And the question I was thinking about is, it's gone out of my mind now. Look at that. I was thinking about the cocodamol. Why are we prescribing? And why are we not...
The other thing you were saying at the time is, NSAIDs.
Yeah, in the NSAIDs.
Non-steroidal anti-inflammatory drugs are anti-inflammatory by nature.
Yes.
So in the short term, they are going to be beneficial because they're going to reduce inflammation in the joint.
Yes.
but you're only using them for part of what they do. They also control pain. And after the inflammation has gone down, the acute inflammation and the stiffness, you continue to take these drugs because of their analgesic effects. Forgetting that they'll damage your kidneys, they'll damage your liver, they'll cause cardiovascular disease.
And your colon lining's all gone and leads to ulcers and everything, bleeding through the back passage. Oh my God.
Yeah, I mean,
side
what I was
effects
saying earlier about these products is when they were designed and approved, they were approved as short-term acute analgesics. Think about it. They are. It's only as we've used them and made them readily available to people over the counter that people take them for months, days, years on end.
Yeah.
Because there's nothing else available, and until they stop working, there's no reason to go back and see your doctor and get something else.
That's true.
And the first thing the doctor does when you go in and say, look, I've been taking 3 ibuprofen 3 times a day and it stopped working. What do I do now?
Cocodamol.
Well, or you would go for one of the COX-2 inhibitors,
Yes.
or one of the NSAIDs that are only prescribable and aren't available over the counter. And then when that stops working, you'll add in a combination opiate paracetamol product. And then when that stopped working, you might go up to DF118 or codeine phosphate or something else. What I would encourage people to do is think about, why are you doing this? What are the expected outcomes from doing it? And is it really good practice? Is it good for your patients to be doing this? Are you actually treating the disease?
No. Why are we not focusing on prevention? Because if we, from the early stages of the arthritis, we treat it as a disease, get people into more information and get them in a lifestyle modification and treat the disease, we could save loads of money for the National Health Service here, right?
Yes, but there's always a but, isn't there?
Yeah.
The treatment that you can do, which is holistic,
Yep.
the whole patient, involves things that aren't pharmaceutical.
Yeah.
It's what your practice is based on. It's physical therapy. It's
Yep.
getting people to understand their bodies better, is to take better care of their bodies, is to lose weight, more
Yep.
exercise, better diet. And there are all sorts of things that you can do at that stage. But remember to what we were talking about at the beginning is this is a systemic disease, but it only affects joints.
Yes.
So to treat it, in effect, you're going to have to treat every joint.
Yeah.
We don't have drugs or
Which goes all over.
injections that are systemic, like we do for rheumatoid arthritis, that are going to treat all the joints. So what you end up doing is just treating the worst joints that are affected. So you end up treating the joint that causes most pain. And we use our knees more than our knees take up more strain than
Yes.
anything else in our body. And 50% of adults will develop osteoarthritis over a lifetime, some more than others.
Yes,
but
yes.
As a whole. And it's one of the biggest causes of disability and cost to health authorities around the world is osteoarthritis. So we end up treating the symptomatic joint. And often in people, as with knees, it's both knees.
So we're trying to cut short the cost by doing just one joint.
We are, and that's where we're on a losing battle.
Yes.
And the problem is we end up treating those joints when often it's too late. I mean, it's not too late because it's going to cause death or a disability, but it's too late in the disease process to have much of an effect on the progression of the disease. And ideally, we should be treating people at a much early
stages
of the disease with things that are going to delay the progression of the condition. But that gets expensive, and it's always a question of balancing out cost-benefit. What are the costs of doing something? What are the outcome benefits? And how many people do I have to treat in order to prevent 1, 10, 100 knee replacements or joint replacements?
So now the last question of this chapter, I want to talk to you about, I want to prescribe or I want to give a perfect solution for arthritis as a disease to my client group. What are the things it should involve?
A lot of it is health education at an early stage. The next thing is really talking to those patients who probably don't come and see you, who are more at risk of getting, and this is where probably primary care comes in, because they're seeing people for health checks and everything else, is the sort of holistic approach to disease prevention, is getting people to live better, more healthy lives, and and to look after their bodies. And we're all guilty of that. Men more than anything. Men abuse their bodies for 50 years and then expect a miracle to happen that, okay, what you've done isn't too bad, you can carry on doing it for a bit longer. Men try and avoid healthcare if at all possible. As a doctor, men are dreadful to treat, because not only they never comply, they never come and see you unless they have to, or they're told to by someone else. And then when they do come, it's an unrealistic expectation. I always remember patients coming to see me, and typically they're men, and they say, "Look, I hurt my shoulder last summer, and we've got the old boys cricket match next week, and I need to be able to bowl next week." It's like, okay, so you did it a year ago, you've done nothing
you managed
about
to come
it,
in now,
and you want to be better by next week to go and do whatever you.
That's where the steroid shots comes in.
Well, exactly, and that's the problem, isn't it?
It is.
Is we're treating chronic diseases with instant fixes that only last a few days and cause problems.
Thank you. This is quite an insightful conversation, and let's catch up on another episode with the further treatment options available for arthritis of the knee joint. And it's great to understand osteoarthritis as a disease rather than just considering a wear and tear.
Absolutely. Looking forward to it.
Thank you.